Welcome to the MSF Patient Referral Project, a research project from the Sweden Innovation Unit to address issues, design, and solutions in MSF's patient referral systems. Referral happens in almost every MSF project. When a patient is too sick to be treated locally, the team will do their best to refer the patient to a medical structure which is more adapted to the care they need. But hang on, it's not always as simple as that. The referral paperwork needs to be completed to go with the patient, and how about the per diem for the patient and their caregiver? How long will this trip take? Did the driver already work all day? Which nurse is available to go on the journey and care for the patient? And what about the referral structure? Does the doctor there know that the patient is coming? What about the invoice if it's not an MSF hospital? How will we know when the patient is discharged? And how will the patient get back home? Referrals are a complex process, and without a robust and consistently applied system, project teams struggle to track and manage patient referrals, leading to challenges in understanding and justifying the costs, as well as struggles to set evidence-based referral policies. The Swedish Innovation Unit worked together with MSF field teams to map existing referral systems, looking for opportunities for improvement. A team was sent to Sudan and Ethiopia and visited several projects, interviewing a total of 56 people, both MSF and non-MSF, including medical, logistics, and coordination staff. Although every project and context is different, similar patterns of challenges emerged from the research results. The team was able to map out 7 distinct points in the referral continuum: the pre-referral preparation, the referral decision and transport preparation, the transport itself, including, when necessary, stopover care and documentation, the patient handover, the patient treatment, the patient's discharge and return transportation, and lastly, patient follow-up. The research team found that the most pressing issues usually had to do with information sharing and communication. Let's zoom in on some of those challenges. Referrals can be sudden, life-threatening situation, and it can happen that other essential people in the project team are not informed early enough in the process. While the project medic will often manage to complete the referral paperwork, this can sometimes be incomplete or is only done verbally. The instruction often lacks specific supplies needed for care during transport. And during the ambulance ride itself, no extra medical notes are taken to reflect changes in the patient's status or any elements of care that might have been provided. When the patient arrives at the hospital, again, the handover is often only verbal. The patient is admitted, and while there is an MSF referral focal person at the referral location supporting the hospitalization, they often have limited power to influence care options and direction as they are not in an MSF facility. It is then difficult to know when the patient is discharged, and if there is no written handover back from the hospital to the MSF clinic, it's unclear what diagnosis and treatment the patient received and if the patient needs to be followed up. This also makes it difficult to justify hospital bills and analyze whether the patients were referred for the right reason and if the referral diagnosis was the same as the treatment diagnosis. And lastly, once we have supported the patient this far, we need to assure that they are both aware and then reminded of their follow-up appointments, which could be 1 week, 1 month, or several months down the road. With all these challenges, projects are working hard to improve their referral processes, but there is no quick fix. During the interviews, some really good context-specific ideas came up, with potential to feed into a more robust, generic, yet adaptable referral system design. Taking those suggestions, the SIU proposes an, at least partial, potential improvement focusing on communication and data management, with the aim for the right person to have the right information at the right time consistently. This would improve appropriate software and tools, the necessary infrastructure, and clearly defined roles and tasks around referrals set at both project and referral site level. It could look something like this. When a patient needs to be referred, the project referral focal person enters the information into a digital referral register. This register generates an automatic SMS to notify the right people, and a phone call to the person with a final decision-making power is made to ensure approval. A standard written referral form with instruction goes with the patient into the ambulance and is updated by the medic during transport with the relevant parameters. Update phone calls are made along the way as needed. On arrival, an updated referral form is part of the handover to the hospital, and the MSF referral focal person at the referral site takes it from there. The referral focal person updates the digital referral register regularly and adds the necessary information for follow-up when the patient is discharged. Once the patient is safely back home, another automatic SMS alert is generated to inform the patient of their upcoming follow-up appointment, allowing time for them to prepare to travel to the MSF clinic. The collected digital data provides an overview, but also allows for detailed feedback and coaching for the project medics and ongoing input into the referral protocol for continuous improvements. So what are our next steps? The MSF SIU is actively engaging with partners who can help make this vision a reality, but we need field locations in MSF to help us assure that the work we are doing is designed with the user in mind. If you are interested, please contact the Sweden Innovation Unit for more information. Thanks for watching.